Hello, everybody, and welcome to our PICO presentation, and we will be doing the ankle and the foot.
So our lower extremities have a significant impact on our day-to-day life, whether an individual is active or not. So it's really important to take care of them. So different ways to take care of your foot and ankle can include wearing proper footwear and orthotics, strengthening your foot muscles, proprioceptive training, and icing after injury.
So my PICO question was, can a runner's efficiency decrease in a metabolic expenditure? Can it improve by simply adding a carbon fiber plate? And I have this fancy little video for us to watch. It's only a minute and a half.
So we've done a series of studies, and this is the culmination of years of work. So we've studied how shoe weight affects the energy cost of running. We've studied how shoe cushioning affects the energy cost of running. And this new shoe that we were presented with is it's the most efficient shoe we've ever studied, or anybody has ever studied. So we knew before we did our study that preliminary testing showed that this shoe was more efficient than others, but we didn't know by how much. And in fact, going in, the expectation was it was going to be about 3%. So this new shoe we're really excited about because it saves 4% of the energy required to run compared to the best other shoes on the market. 10 years ago, everybody was saying you should run barefoot with the lightest possible shoes. And the pendulum has swung back based on data, which is nice, to show that cushioning actually saves energy and therefore can improve performance. We can calculate that this shoe is going to improve running performance by somewhere between 3 and 4%. The world record now is just under 2 hours and 3 minutes, and if we can enhance performance by 3%, that theoretically should get a runner well under 2 hours. 2:03 marathon is a rare event in and of itself, so we don't expect that it's going to happen necessarily tomorrow, but it could happen very soon, and this shoe definitely is a big assistance towards getting to that goal. So we've done.
All right, and for anyone who doesn't know, using that technology, the 2-hour marathon barrier was broken. And actually, fun fact, half of that video was actually used for a different study, but we're not going to touch on that. And so that video is literally this article right here, The Biomechanics of Competitive Male Runners in 3 Marathon Racing Shoes, a randomized crossover study. And so it's a randomized control trial, level 1A, with 18 male subjects ranging from 19 to 27 years old, running below lactate threshold at 14, 16, and 18 kilometers per hour, which is pretty fast to be below your lactate threshold. And so the physical interventions, each participant had to do 6 by 5-minute trials at one of the 3 velocities above, which were randomized, with one of the 3 shoes shown in the top right, which is the Nike Marathon shoe, the top one before the new ones came out, the shoe in the middle, the Adidas shoe, which was used to break the previous world record, and then the prototype shoe with the carbon fiber plate. And so they had to do a 5-minute trial and then 5-minute rest to change shoes. And each shoe was worn twice per visit. And then the last 2 minutes, the expired gas analysis system measured some maximal rate of O2 and CO2 production. And they calculated the metabolic energy consumption with the Brockway equation, which just uses oxygen uptake with carbon dioxide produced, subtracted by a value of nitrogen. And then if any patient went above their lactate threshold at any of the velocities, they were excluded from this study. And then there was a subject testing, but then there was also the mechanical testing of the shoe shown in the middle about with the actual shoe, where they would apply a machine to compress the midsole in a vertical direction, so just one plane of direction, but it would match the general time of ground reaction and the force generated during running, which is around 2000 newtons at 185 milliseconds. And so their findings, the energetic cost for running in prototype shoes, the one in the top right, which has the carbon fiber plate, was 4.16 and around 4.01% lower than in the previous Nike and Adidas shoes. And then also these prototype shoes generated slightly greater peak vertical ground reaction forces, slower step frequencies, and a longer contact time. The prototype shoe was also more resilient, meaning it gave 87% energy return than the other two shoes, which is that graph in the middle there. And if you look at that, it just goes right along with the photo above. And the top line of each graph is the shoe deforming from the force. And the bottom line is the recoil of the foam as the force returns to zero. And that area between the two lines is actually the energy lost as heat. And then the area below that bottom line, which is shown in joules with the percentage, is the amount of elastic energy returned. So as you can see, the one all the way on the right, the prototype, has the least amount of energy loss as heat and the most energy returned. And so going along with this, though, the prototype shoe not only has a carbon fiber plate, but actually has a completely new foam, because the Adidas one uses something called TPU, the Nike one on the left uses something called EVA, and the prototype has something called PEBX, where when listening to the researchers and in their discussions, they believe that it's not the carbon fiber plate, but actually this new foam that gives the responsiveness and the positive impact for the runners. Because there's also been a study done that looked at just inserting a carbon fiber plate into shoes, actually into that same Adidas shoe in the middle there, and they found no differences in the results except that the MTP extension was lowered. And so a weakness for this study actually was that mechanical testing, though, as it was only one-dimensional when running is, as we know, three-dimensional with different foot strikes, maybe different forces, different heel, forefoot, or mid strike. But the strengths of this was actually that each participant had to record 24-hour log of like everything they did in a day to try to reduce the external factors on performance. And if the researchers perceived anything to have an impact on the study, they postponed it. And like I said before, the machine would try to replicate running. And then to equal out the weight for all the shoe trials, they added lead pellets discreetly to the shoes. And then a major weakness is the man who we saw in the video with the glasses, Roger Cram, is a paid consultant for Nike. So of course, there's going to be some bias there, as long as some other individuals involved with the study, they were funded by Nike.
So my PICO question was if the use of shoe orthotics impact the prevalence of shin splints. Oh, well, and my study looked at the prevalence of both back and leg pain in military conscripts with the use of orthotics. It was a randomized control trial, so 1A level of evidence. And the subjects included 146 new military conscripts, all aged 18 to 24 years old. There was a pre-screening before the study to go over exclusion criteria, which made sure that there was no prior incidence of leg or back pain in the participants, as well as no use of orthotics beforehand. There were 77 in the experimental group, 69 in the control group. And for the orthotics, they were custom fit to the bottom of each participant's pair of military boots. And the same boots were given to the people in the control group. These shoes with orthotics were then worn for 3 months of service. And during this time, or in between when they had them on, they did a post-test afterwards to check if there was any pain in them afterwards, including both just general pain in the back and legs, or specific conditions, including sprained ankles, Achilles tendonitis, or shin splints. And for the final observations, they found that the orthotics group did find reduced incidence of injuries, with 56% incidence rate of injuries in the control group and only 36% in the orthotics group. Less shin splints in the orthotics group, with only 5% incidence versus 24 in the control group, and about half less days taken off of duty in the orthotics group. Now, one of the things I really liked about this study was that they looked at specific impairments like shin splints in addition to more general ones like leg pain and back pain. And they also did a pretest to confirm that they didn't have any prior injuries before going into the trial that could be unfairly counted. And the medical examiners who were taking care of the patients who came in for injuries did not know which groups they were in. So they treated them all the same and were specifically told for the study not to prescribe anyone with orthotics as a means of recovery. And it also had a pretty big sample size with 146 participants. However, a couple issues I had with the study were that there wasn't any questions assessing how severe the pain was. It was just whether the pain was there or not. So I would have liked to see if within the people who reported general leg pain or back pain, if it, like where they would rate it on a scale of 1 to 10 for how severe it was, to confirm if even if it can't prevent leg pain all of the time, it can reduce how severe it is for each individual. Another issue was a significant amount of dropout from the participants, especially in the orthotics group. There were 77 in the group to start, and 19 of them dropped out by the end of the study. So the researchers weren't able to get that data. And also it only focused on the general use of the orthotics rather than how the orthotics function with people who are exercising.
All right, my PICO question is, what foot postures increase a runner's chance of injury, and what causes these foot postures? So right off the bat, I'll tell you that my research ended up taking a little bit of a different direction and doesn't directly answer this question, but I left it because that was my original PICO question, and that's what I set out to find. So I have 2 articles here. I ended up using 4 because my research started going in a different direction. So my very first article looked at individuals with various foot postures, so excessively pronated, neutral, supinated, and excessively supinated. What it found was that excessive foot postures can cause overuse injuries, but then at the end they said there needs to be more research. So then comes this first article listed, this 26-person study. It's a level 2A evidence. It's a cohort study. So it had 17 individuals with what they call a normal foot posture or neutral, and 9 with overpronated foot postures. So that pronation, you can see in the top right corner, it's that rear foot eversion, that dorsiflexion, and that abduction. But these individuals, despite having that overpronation, were asymptomatic. So then the researchers, what they found is that those asymptomatic individuals compensated within their foot. So they adjusted the morphology or the muscle setup in their foot a little bit. So they found a larger cross-sectional area of abductor hallucis and flexor digitorum brevis. So these are 2 medial muscles that support our medial longitudinal arch. And with that greater cross-sectional area, they anticipated it being stronger, so the individual was able to control their foot a little better. So what those researchers ended up finding is that foot posture is not necessarily causative of an overuse injury. So then the same researchers did this next study that I have listed, again, a cohort study, level 2A, and it was a 30-person study. All of these individuals had overpronated feet, but 15 of them were symptomatic, 15 were not. So they all went to the same clinic. 15 of them were to treat those overuse injuries, 15 for other injuries or impairments. So common overuse injuries could be medial tibial stress, plantar fasciitis, patellofemoral pain, or recurrent ankle trauma. So they looked at the foot posture and tried to figure out, okay, why do some have symptoms and some don't? Again, what they found was that this time the researchers really focused on abductor hallucis because that's the most medial muscle, and they thought it was the intrinsic muscle that supported the medial longitudinal arch the most. So very similar findings with that larger cross-sectional area. And the graphs up at the top, the main one I want to focus on is in the top row, the middle graph. That shows the forefoot abduction. So the symptomatic group showed greater abduction in their forefoot, which, as you can imagine, places stress on those medial soft tissue structures and causes pain and other overuse injuries. So with a larger cross-sectional area of abductor hallucis, the individual was able to kind of straighten their foot out a little bit and not have as much stress on their foot and thus less overuse injuries. So overall, between these two studies, same researchers did them, they were able to support the conclusion that the foot posture may not necessarily automatically indicate that an individual is going to have an overuse injury. So one thing they mentioned at the end of the second study was something called the foot core. So many of us know about like our lumbopelvic core, which is just the typical core you think of when you picture the core right around your trunk. But they think we should also be placing a focus on our foot core system, which is kind of where we come in as PTs, because if we have these stronger intrinsic foot muscles, it's going to help control our foot during movement and thus decrease our symptoms. So as PTs, we can end up strengthening these muscles. But then another implication for us is to kind of alter our standard of care. So currently our standard of care focuses on bracing and orthotics. And although these can be very helpful and can be very necessary, they may not be the best for prolonged use because, as we talked about with Dr. Opit this summer, prolonged use of bracing can end up leading to our muscle atrophy over time. So if we automatically put a patient in orthotics and then move on and don't think about strengthening those muscles, it's doing the job for those muscles and they're going to atrophy, and the problem isn't going to go away. So bracing and orthotics are very good for like short-term benefits, decreasing the pain, helping with that acute issue. But over time, we need to be strengthening the muscles. So strengths and weaknesses is going to be a small sample size for weakness. So 26 or 30 people. They found all these measurements like with that forefoot abduction while walking instead of running. And they didn't talk much about an intervention. So I got a fourth article that just talked about the foot core, and it still only gave one intervention. And it talked about with like your foot flat on the ground, trying to like shorten your foot, which is just like raising that arch up and doing that repetitively, but still not many interventions. And then, but a strength, however, is looking at multiple variables. So once these researchers found out like, okay, the posture isn't causative, they looked more into what is, like why are some individuals symptomatic and why some aren't. And that's where the muscles came in.
Hi, my PICO question says, does proprioceptive training play a role in decreased risk of injury in athletes? If so, what interventions reduce this risk and at which joints is this helpful? So my study was called Proprioceptive Training and Injury Prevention in a Professional Men's Basketball Team, a 6-year prospective study. The purpose of this study was to assess the effectiveness of a single stance proprioceptive training program based on high frequency instability to reduce ankle sprains, knee sprains, and lower back pain. My level of evidence was a 2 because it was a prospective comparative study. There were 55 active basketball players from the First League Championship of the Italian Basketball Federation out in Italy. That was pretty cool. The ages ranged from 18 to 45, so a pretty wide range of players over there. But all 55 stayed through the entire 6-year study, which is pretty sweet. The same strength and conditioning coach managed all the training protocols throughout the entire 6 years as well. So that kind of adds some consistency there. So the intervention, the intervention was a single stance stability training program. And it was over 6 years, broken into 3 bienniums, so 2 years for each one. So for the first 2 years for that first biennium, used classic proprioceptive training without measuring any specific statistics. This was to kind of provide a baseline so that everyone was measured at the beginning, and then they underwent the first 2 years of your just classic stuff. So they really used mostly like rocking instability and uneven surface training on 1 foot, but they didn't use any devices to measure this data. For the second biennium, so the second 2 years, they used more quantifiable training by using an electronic rocking board, postural readers, and infrared sensor bar. So in this time period, the training just became they were able to pull data from it, which was really helpful in the long run because you need something to compare to, right? In the third biennium, so the last 2 years, they basically took what they did in the second biennium and they just increased the intensity, decreased the length of each training period, and decreased the rest periods to try to make it a more intense workout overall. And the interventions that they would do is they would do 2 eyes open and 4 eyes closed single stance tests. And so what would happen is they'd be on a board and the board would kind of shift back, forward, side to side, just pretty much anywhere in that in that plane there, that horizontal plane. It would just shift into all the different planes, and you had to stabilize your body on one leg. And they were each for 30-second trials. So they basically completed 3 minutes of training with resting in between. And that changed during the third biennium where the intensity went up. So the board was moving a whole lot more, and that movement of their trunk was measured with the infrared sensors. All that to say, the findings showed a significant reduction in the occurrence of ankle sprains by 81% and low back pain by 77.8%. Those were both found to be statistically significant through an ANOVA test from the first biennium to the third biennium. Proprioceptive control was increased significantly compared to new entry players, and that's what they used as their test against. So the team obviously gets new players every year. And so they would test the players who had been in the program against the new players who were coming in. So usually younger players, very athletic, but again, they were able to see a statistically significant difference between their proprioceptive control against the new players who had not undergone this training. So some of the strengths of the study were that it was a longitudinal study. I mean, it's rare that you have a study stick with the same group with the same trainer for 6 years. So that was pretty sweet. Some of the weaknesses, though, were that it was unable to differentiate the results according to the presence or absence of a history of ankle sprains. So basically what that means is they were unable to determine if people who had a history of injury at that site, if it was because they were strengthening an area that was already weakened, or if they were actually, if it was the proprioceptive control that was reducing those injuries. And there was a lack of a true control group and randomized treatment. So it would have been nice if this was a blinded experiment to get to level 1. But the new entry players served as a pseudo control group, but it wasn't a true control group.
All right. Hi, everyone. My PICO question is, in patients with soft tissue injuries, does icing help or hinder the healing process of that specific injury? So my study was called Topical Cooling or Icing Delays Recovery from Eccentric Exercise-Induced Muscle Damage. And this was a randomized controlled trial, and level of evidence was 1A. So the subjects that were used were 11 male college baseball players, and they all played in the National Baseball League, and they were the exclusion criteria for this study included the presence of a musculoskeletal disorder. So if you had a musculoskeletal disorder, you were not allowed to participate, and they were randomly assigned to either the sham group or the topical cooling group. And so before this intervention started, none of the subjects performed any weight training or any other exercise training for at least 1 week prior to the trial starting. So the intervention included 6 sets of 5 eccentric contractions of the elbow flexors with 2 minutes of rest in between each set. So what they did was basically the down phase of a bicep curl. So they started from full elbow flexion and they completely extended their elbows to 180 degrees, and then the arm was actually assisted back up to a flex position by the researchers, and this was to eliminate any concentric contractions of the elbow flexors. So the participants or the researchers looked at both the dynamic flow of blood flow, the muscle damage markers, the inflammatory cytokines, subjective pain level, and fatigue, isometric muscle strength, both before and after the isometric or the eccentric exercise. So for the topical cooling group, they had 5 sessions of 15-minute cold pack application to that exercise muscle. And that occurred at 0 hours, 3 hours, 24 hours, 48 hours, and 72 hours after the eccentric exercise. Whereas the icing group or the sham group just rested after the exercise was performed. So the findings of this was that the subjective measures of pain and fatigue were actually slightly elevated in the topical cooling group, and which is weird, but it's also subjective, so that is where a little bit of weakness comes in. So there was also no change or decrease in the release of inflammatory cytokines in the topical cooling group. So with inflammation, damaged muscle cells are eliminated by phagocytosis of macrophages that come in, and it's important for that muscle recovery. So with icing, it actually tends to eliminate that inflammation, which then halts the inflammatory cells of entering, which can prove to be a problem with the healing of that muscle. It was also found that topical cooling was unable to relieve, but almost seems to increase the pain after that exercise. So, which is different than what we're always taught. We're always taught that icing an injury or icing pain will help reduce that pain or decrease the recovery time. So it was interesting for me to find this article. So some of the strengths of this study was that they were able to really control what variable they wanted to see to be only eccentric contraction. So with the researchers helping the individuals up to the flex position, it eliminated the presence of a concentric contraction. And also the fact that it was randomized, so either to the topical cooling group or the sham group. But some of the weaknesses of this study was that it was short term, so it only really lasted 72 hours in which they looked at all of the variables before and after. So it would make a little more sense to even see the healing of that muscle maybe a few days out rather than just a few more days out than rather than just 72 hours afterwards. And they only use college-age athletic males, so it might be interesting to see how an older individual's muscles may heal after this, just because we have learned how aging does affect all of our body systems. So it may be different than what we see in an athletic male who is young. And also the fact that it was a small sample size of only 11 males. So, which was also confusing just because how do you split 11 in half to be either the sham group or the topical cooling group? You can't really do that. So the findings was overall that the results provided evidence that the topical cooling group does not enhance and seems to delay the return to normal of muscle damage markers and objective feeling after eccentric exercise. So the overall summary, putting all of ours together, it is important to find shoes with proper support or even orthotics may be helpful to the inclusion of your shoes for both running and daily wear. And proprioceptive training can also help to reduce the risk of injury and lower extremity pain. Yet, some of today's widely used standard care interventions may not be providing as much benefit as previous thought, such as icing and prolonged orthosis.
All right, and our discussion questions is, have you had any experience using an orthotic on your foot/ankle? If so, was it successful in relieving pain? And what is your take on the icing debate? Do you have experiences that support icing and injury? Questions. Thanks. And references.